lung volumes prior to a cough. So what we teach all of our patients who are capable of doing it is to stack breaths, or what I like to refer to as lung volume recruitment. So what you're doing is that, as compared with the spontaneous and limited vital capacity, you're actually stacking a breath, holding that breath with the voice box, stacking another breath on top of that, and whatever one may be capable of doing, and stacking these breaths on top of each other in order to achieve a much bigger volume, which is called the maximum insufflation capacity. And really the ability to use non-invasive ventilation for an extended period of time is dictated not by the hours of use in a 24-hour period or by the absolute vital capacity. It's dictated by this MIC-VC difference. And as long as one can maintain a substantial MIC-VC difference, probably between 500 cc's and a liter, one may be successful over a very long period of time with entirely non-invasive ventilation, even up to 24 hours. So just illustrated another way, what we're doing is asking patients to stack breaths on top of each other to produce this, albeit artificial, but importantly, large vital capacity. So you're trying to restore the lung volumes closer to a normal range. So here's an example of a young man with Duchenne Muscular Dystrophy. He could in fact even be in the room, whose vital capacity is only 7% of predicted. 370 cc's. So that is a vital capacity which is probably incompatible with survival without some sort of ventilatory support. When you teach this individual how to do lung volume recruitment, they move from this very small vital capacity, under 500 cc's, to this much larger maximum insufflation capacity. And you can see that there is both a range of motion that's occurring in the lungs and the thorax, as well as the achievement of a much higher peak expiratory flow, which will be correlated with the ability to cough. So these peak flows are much, much higher. And if the remarkable thing is that if you walked into a physiotherapy student with your arm in a contracture and said you had trouble getting your sleeve on, well, they'd know exactly what to do. Well, we'll just get you on a range of motion exercise program, and the arm may not be that much more functional, but at least you'll be able to, your quality of life will improve because you can put your shirt on and off. This is a vital organ, and yet we forget that it has lost compliance. It has lost a range of motion that we need to try to either maintain, I think preferably, or try to reverse if such efforts have not been done in the past. So I think this is a very easy, very inexpensive, and very effective strategy. So this small curve is the spontaneous curve, and this is the curve produced after lung volume recruitment. So here's that same pulmonary function expanded. And so this individual goes from under 400 cc's to almost a liter, which is a 165% increase in vital capacity. We can also see that peak cough flows improve from 80 liters per minute to 130 liters per minute. Maximum expiratory flow increases from 0.44 to just over 2.56 liters, so that's a 483% increase in peak expired flows. Now, one could argue that this 130 is still not adequate, and clearly a manually assisted cough needs to be added to this. If still inadequate, then the cough assist device needs to be considered. And I'm going to show you some data that has not been shared anywhere yet, because I don't suspect that anybody here is going to publish it before I do, though I could be wrong about that. These are vital capacity measurements in young people with Duchenne muscular dystrophy 24 months before and 24 months after initiating lung volume recruitment. And although it's fair to say that the vital capacity in folks with Duchenne has this curvilinear function where it does stabilize with time, But there's a very impressive stability and even improvement in vital capacities in many patients who start lung volume recruitment. For example, these 3 patients who clearly demonstrated marked reductions in vital capacity, their rate of loss, who stabilize or even improve. I mean, this is not a statistical variation. This is a very important clinical improvement, in an otherwise, a course which otherwise demonstrated further reduction. So, fortunately for Sparky, Zeke knew the famous Rex maneuver. So it's not sufficient just to increase vital capacity, as we've done here. We can, as I've shown you, that peak cough flow was still inadequate, so that adding a manually assisted cough after lung volume recruitment further increases the vital capacity, and more importantly, increases the peak expired flows, sometimes to a very substantial value over what you can achieve with volume alone. So here's an example in a gentleman with Becker's muscular dystrophy. Whoops, sorry, beg your pardon. Let's try that again. So we're using personal protective equipment, which is certainly what we do in the hospital. So he's taken his own breath in, and Kathy is stacking breaths on top of each other. And then he's holding the volume in now to get the peak flow measure in, and then doing a manually assisted cough. He's been doing that for about 10 years. He's very, very skilled at it. So this is the cough assist device, which again may be necessary if peak cough flows remain inadequate. And this is a device which is a positive pressure, like a vacuum cleaner motor, to which you can apply positive pressure. You can be attached to the positive pressure or the negative pressure. So the positive pressure increases lung volume, and the negative pressure, you switch immediately from positive to negative, and the negative literally vacuums out the airway. So it mimics a cough, and you can get peak expired flows of 12 liters per second or greater. And it works extremely well through a cuffed tracheostomy, slightly less well through an uncuffed tracheostomy because you have to rely on glottic closure then. And we've also used it through endotracheal tubes with great success. But most often, of course, it's preventive, so we use it through a full face mask. This is a young woman with spinal muscular atrophy, and Carol is using the manual cough assist device. So we ask the patients to just breathe in, and cough, 2, 3, and in, and cough, 2, 3. So you notice the switch from positive to negative is immediate. So the faster you make that switch, the steeper the slope of change is, the higher the peak expired flows are. And that's very important. And of course, this can and should be combined with a manually assisted cough during the exsufflation or negative pressure phase. So the key, I think, is really prevention. Okay, regular lung volume recruitment, assisted cough with colds, and this is the best way of preventing pneumonia and acute respiratory failure. Adding lung volume recruitment with the manual assisted cough, using the cough assist when necessary, and of course you can add the manual